Assalamu alaikum. Welcome everyone on board. Today we will just try to have a quick review of some of the procedures which we do as non-operating room anesthesia. First of all, generally, what are concerns, Abdurrahman? What things come into the mind when you think about NORA, like an anesthesia out of main OR?
Sir, it will be an unfamiliar environment, and there will be limited space. Proper equipment may not be present there. Proper assistance may not be readily available. Uh,
Okay,
and
so actually, this few of the words which we are saying will make you unsafe anesthetist at all. So I think you can say that it's not the familiar environment of OR, but if facilities are not there, why are you providing anesthesia? Okay, so don't tell about facilities because if the facilities by of the performing a safe general anesthetic is not there, uh, should we do it? Yes, Abdurrahman.
yes, sir.
So,
Yes, sir.
like basic monitoring should be there. Okay.
Yes, sir.
The
Sir,
all the anesthesia equipment. Can you tell me, just
yes.
enumerate what things should be there for a safe performance of anesthetic? Yes.
Sir, anesthesia workstation, oxygen
Works.
supply, backup
Works.
supply,
Okay.
uh, and different emergency drugs
Emergency
and trolley,
medication.
airway drugs and trolley, suction
Emergency.
machines.
It is also called as crash cart. Okay, you can use the word crash cart because emergency trolley is also good, but crash cart is the one which is and all the facilities for performing a CPR. Okay, so if these things are there, just tell me one thing: why you are saying not facilities? Okay, so
Yes,
yes, it's a valid point that maybe manpower, limited manpower with reference to trained anesthetists. Maybe one anesthetist is there. Okay, or maybe one is consultant and one junior anesthetist is there. So limited manpower. Okay, and unfamiliar
the
environment.
table. Uh,
And okay, I'm sorry, what you are saying?
I was saying that table may not be uh,
Yes, like it's
adjustable.
not the proper because maybe okay, now just enumerate what are the places so we can think. So MRI is one of them.
Yes,
What else?
CT scan,
CT scan. What else? Cardiac cath lab,
yes, sir.
uh, uh, ERCP, GI endoscopy, and intervention radiology.
endoscopy
Uh,
suite, endoscopy
yes, sir.
suite. Okay, interventional
Maybe
radiology.
maybe ECT,
Yes,
sir.
sir.
Very good. Interventional radiology. ECT. ECT. Okay. So actually, there is another what is called as Bilal can have few words about it. If Bilal, you can just recall some of the radiation oncology thing, which if you can, Bilal, are you free to talk? Okay, I will. So because that is what is called as brachytherapy and something like that. Okay. So radiation oncology is also something. Then few more thing I am just recalling. Sometime they are doing what we intrathecal intrathecal chemotherapy. Okay. Then they are taking bone marrow biopsies. So you can make a list of the procedures which are done outside of OR. Okay. So so if we are performing anesthesia, we should be more careful. Everything should be there. whatsoever possible things should be there. Not only the emergency medication, the emergency facilities, everything should be there. Ambu bag, emergency cylinders, all airway equipment, because you have limited manpower. So if you have limited manpower, you cannot send too many people go back to bring everything. So anything which can be needed in the OR should be there. Okay. Because if the facilities are not there, you should not perform that procedure at all. You should not give anesthesia. Okay. So that's what I wanted to point out. Abdurrahman, are you clear?
Yes, sir.
Okay, so now we will just try to have one by one. Let's discuss few common things. A number of time the procedures which are going, or they are day cases. A number of time, not necessarily. So the concern with of day surgery will be there. So this is one point. Then quick anesthetic, because the procedure is very quick. A number of time, quick anesthesia, but at the same time, patient should not move. Okay. So this is another thing, that you not only you need to have a good depth of anesthesia, but you should make the patient awake immediately. So that's another thing you should be taking care. So day surgery, quick anesthesia, very mobile, very immobile state. Okay. So then if you are talking about MRI, so MRI sensitive things, okay, so, or compatible things should be there. So this is another thing which will be there. Then as we discussed, the table position, this is a big thing, table. And another thing will be the radiation safety for the anesthetist and the whole staff. Radiation safety, the like you should have lead shields. And with reference to lead shields, the lead shields should be good. And then there should be a radiation band. There is a radiation meter which should be there with all the medical personnel working in areas where there is radiation exposure. And there is a yearly safety profile which you need to measure, because like actually in the list which we make, one thing I miss is actually lithotripsy. I know that in a number of hospitals it's not there, but lithotripsy is also a place where they are not only doing lithotripsy, they are also doing short urological procedures. Short urological procedures like removal of this digestant, or quick cystoscopy, check cystoscopies they are doing in the and this lithotripsy suit. Okay. So this was the list which I didn't write. So I just recalled my mind. So I'm just telling you again. So radiation safety, table position, and then a number of time limited access to the patient. Okay. Okay. Another thing, because I will be going specific things as well, but right now we are just making our concept. What are the common things? A number of time these places are very cool. Okay. So chances of hypothermia is there. This is another thing. Then a number of time the patients coming here, there are specific uh, population of the patients, or special, like in MRI, a number of times there are babies, very young babies, which are coming for diagnosis of some syndromes. Okay, developmental delays, ADHD. There are chances of epilepsy. So these patients will be there with reference to MRI. If you're talking about endoscopy, so the specific patient group may be very unstable patient with GI bleed, very unstable patient with cholangitis. Okay. And also sometimes they are coming for diagnosis of certain diseases, autoimmune diseases. So this will be another challenge, that you have specific population or specialist specific patient group. Okay. So okay, let's discuss one by one few of the things. So MRI, they will give you a scenario that a 4-year baby or 1-year baby for MRI. So how will you chalk out the concerns? Yes, Abdurrahman, or anyone else?
Sir, my concern will be related to physiological, pharmacological, and anatomical differences in pediatrics.
Okay.
They will be and related to the non-operating room anesthesia.
Okay, Abdurrahman,
So,
just improve this sentence that because of physiological, pharmacological, anatomical changes in a pediatric age group, we have some challenging anesthesia conduct. This should be the word. If you are only saying this word, this is incomplete. Okay.
okay.
So, because of physiological, pharmacological, and anatomical changes in a pediatric patient, we have challenging conduct of anesthesia with reference to now you can say with reference to anxiolysis, with reference to IV lines, with reference to consent, with reference to difficult airway, with reference to
Okay.
fixed cardiac output, limited liver and kidney functions, high blood volume, initial doses more. So like you can make a sentence out of it. Okay.
Sir,
If
I think it would be better if we say that environmental concerns are and the patient-related concerns, staff
Safiullah,
safety
Safiullah,
concern. Sir,
I'm sorry to interrupt you. The thing is that yes, classification is important, but don't make difficult for you. Okay. If you will go in the details, like you can, I'm not saying that you are saying wrong. You are saying absolutely right. You can make like this. Whatever way you want to do in a way that you don't hurt yourself. Okay. Because sometimes some people like say pre-operative, intraoperative, post-operative, so they are so compulsive for it that they are trying to divide, and then in division sometimes they will forget. So that's the easy way which I tell, try to tell maximum things in pre-operative, so that will cover everything actually. So similarly, if you can divide it and into environmental and patient factor and anesthetic factor, I'm not saying it's wrong, but again, because you have very limited time to express yourself, so it's better whatever, if you are able to disintegrate the things in a nice way, okay, fine. If you are not, don't hurt yourself. Okay. I hope you understand what I'm saying.
yes, sir.
Okay, please, you can try, please speak out. For one word we have seen about this physiological and consideration. What else you will say for MRI?
Sir, are you asking me or Dr. Abdurrahman?
Now I am asking you.
Okay, sir. Okay, sir. Sir, like we have
Now
discussed
you have to
earlier.
finish MRI yourself. So keep on answering.
Okay, sir. Sir, we have a child, so we have child-related concern, like discussed earlier. Child physiology, anatomy, and pharmacology are different from adults. So the other thing we have to do MRI. So the MRI related, like its magnetic field concerns, the limited access concern. There is hypothermia concerns for the child and for the staff as well. The staff staff exposure to ferromagnetic radiations, and then if it is any of some metallic objects in the gauze lines that could harm, those are concerns, and of course the hypothermia concerns. And if we have to do MRI for the child, we have to give anesthesia. For that, the anesthesia is given under supraglottic airway device with deep sedation, so that the child is unable to move. Uh, so anesthesia with a supraglottic airway device. But
Why
the
you are saying
equipment checklist.
supraglottic airway device? You cannot intubate, because in the exam, if you will say in a closed ended sentences, then it will be a problem. You can say that we can do it in supraglottic airway device. Now that the statement is
Yes,
totally changed. If you are saying
yes.
that we do it in the supraglottic airway device, now you are fixing yourself. They can ask you why not endotracheal tube?
Sir, of course, it can be done in supraglottic airway device as well as in endotracheal tube intubation as well.
Yes. So now you
Sir,
can, I hope why I'm pointing this out. because in the exam, that's the way we closed. No, don't say closed worded sentences. Okay.
Okay, sir.
Okay.
Sir,
And one thing I have another objection. You were saying ferromagnetic safety. What's that one? What do you mean by ferromagnetic safety?
sir, it means the metallic object in the magnetic field. Any metallic object in the magnetic field
Okay.
is avoided. And
Okay.
our monitoring and anesthesia equipments are MR safe, like anesthesia
Okay.
machines or monitors or saturation probe or ECG. Suction devices, oxygen cylinders should be outside. So either these things should be outside with the MR room with long tubing, or
Mhm.
it should be MR safe.
Okay.
And the drugs delivery would be delayed because of long tubing.
Okay.
And after preparations, I would give induction with monitoring continued along with intubation, and then I would
Okay.
also
Okay. Just a
in
second.
coordination with
A question which they will ask you. What is the working principle of MRI? How MRI works?
working principle of MRI, sir.
How MRI works?
Uh, sir, I'm not remembering that.
Abdurrahman, do you know it?
Sir, in this high magnetic fields align the atoms and then uh, align the
No,
atoms.
actually, there are two magnetic fields. One is constant and one is constantly switching on and switching off. When it switch on, the protons go into high energy. When it is off, it comes to down to the normal energy. This jumping of protons going up and down is different in different tissues according to the pathology, according to the bone, according to the soft tissues. So this thing is caught by the monitor, and this is representing in the form of the image. That is the basic working principle of MRI. One is constant and one is constantly switching on and switching off. So that's a thing. And you can in addition to whatever you are saying, at the same time you can tell about helium. Okay, because the MRI, this is having a very big amount of helium, and if any malfunction occur and the helium is released, there may be hypoxia. And so there is a hypoxia monitor and oxygen sensor in the MRI suit which detect any hypoxia. So this is another thing which is very important. And in addition, of course, you told about hypothermia, noise. The noise production is even up to 85, if I'm not wrong, 85 to 90 decibel, something like that, which is quite high. And then rest of the things you told nicely, like limited access, you have to fix the tube nicely, and then the depth of anesthesia is maintained throughout so that the patient does not move. Okay, and like all the MRI compatible equipment should be there, because if you put this normal, there will be burn. If you put the normal, you forgot to remove the pulse oximeter and you put the patient inside because it is tied, so it can cause burn. And there are actually very bad burns, or case reports of bad burns with the MRI within the MRI. Okay, so I think that will be. They can ask you what is MRI compatible, what is MRI safe. So these are 2 3 terminologies you should be knowing. Okay.
Sir,
Anything missed? Anything missed in MRI?
sir, yes, I have heard they ask that if a patient has cardiac arrest during MRI, then
Okay.
what to do? They asked this question
You
previously.
will pull out and immediately start a little. You will make it, because there are MRI like these areas like this. So you will come out of the near part and then you will do the CPR.
Yes, sir.
because you cannot do the CPR inside the MRI. So you have to pull out the patient out. Okay.
Sir.
Okay.
What about
Sir,
CT scan, sir?
can they
Can
ask
we?
about the its power? Like I have heard there are three Tesla, four Tesla. I don't think
Yes,
so. Sir.
actually, the thing is that now all of you, because you are listening to me every day, so you should know that I am very bad in cramming these facts. Okay. So these are cramming stuff. So just a second, I try to run away from them. I will show you. For that, I need to have a look on the data. Okay, I will show you because they can ask you about just a second, please. What is MRI? MRI. Like yesterday, I'm pathetic in laser. I'm sorry for it. Light amplification by stimulated emission of radiation. Okay, let's have a look here. Uh, so Tesla is a big, so 10,000 gauss is equal to 1 Tesla. So you should be knowing the lines. You see, this is what I was telling you.
Yes, sir. I think
So this
five
is,
till up 5 gauge gauge line.
yes, our
Uh,
safety line is usually demarcated at the level of 0.5 M Tesla. I don't know what is this M. Uh, 5 gauss, within which pacemaker will malfunction. Okay.
yes,
Therefore,
sir.
unscreened personnel should not enter. See hazard section below.
Yes,
Okay. So, and the second line is demarcated at 50 gauss, within which a significant attractive force will be encountered on all
yes,
ferromagnetic objects, which risk become. I forgot to remove my ring. Okay, and it was pulling, like I was feeling a pull in my finger. I and then if you happen to take any credit cards or any smart watches, anything, the data can be washed. Okay, so this is another thing. If like if for example, if any patient with implant, it can dislodge intraocular implants, the orthopedic implants, like they can have serious problems. Then you see, uh, such items include gas cylinders, needles, watches, floor cleaners, patient trolley. Within this line, anesthetic infusion pumps may fail due to the effects of magnetic field. Okay. So while these line of maker are often referred to theoretically in MRIs, in practice, many MRI units are simply divided into safe zone outside a scanner and the control hazard zone within the MR examination. So that's what is there. So presence of strong magnetic field, this is one thing. Ferromagnetic objects and projectile effect, this is second thing. Okay. And yes, another thing is see transdermal drug patches, insulin infusion systems. Uh, these things all are problematic. Okay, implants and foreign bodies, equipment and monitoring issues. They will put it about uh, restricted access, high acoustic volume. So that's what you see, 85 decibel. Only few things I recall. Noise above the level can be produced during MRI due to the rapid switching off the gradient coils. So this is one scavenging of anesthetic gases because the scavenging will not be working nicely. Uh, so quenching of superconducting magnets. I have told you about it. Okay. Uh, Quenching will release helium. Is a process involving the rapid boil of the cryogen cryogen that causes an immediate loss of superconductivity. This may occur spontaneously as a system error during installation, services, and power-ups, or may be deliberately induced in order to shut down the magnetic field. If this happens, the magnetic field will be lost and large volume will be produced. That's what I was telling you in very simple word. Okay. So this is normally vented to the atmosphere through a quench pipe. In event of damage to the quench pipe, the buildup of human within the scanning room, if this happens, all will be sleeping. Everyone will have hypoxia if they are not detected. So everyone inside will have asphyxia. Okay. Uh, okay, so hazards of MRI during pregnancy. So MRI unit may pose hazards to the development fetus, including exposure to strong magnetic fields, high noise levels, and unscavenged anesthetic gases. Okay, this thing I forgot. In almost all the procedure, whether it is interventional radiology, CT scan, there is a concerns of contrast. So contrast, whenever contrast is there, you should check the baseline renal functions, urine output, okay? And because if they are giving, and when they are giving, you should have availability of management of anaphylaxis, because this can cause anaphylaxis. You should have antihistamine, epinephrine, steroids, these things available. Okay. Maintenance of body temperature. So patient groups, this which I was telling you: seizures, claustrophobia. Okay, critically ill patients coming for patient with high ICP. So I think we have covered in a simple way intensive care patients requiring the things will be the same. Okay, like that's why whenever they are bringing any patient, in a simple way you can say that everything should be outside the line where the high magnetic field is there. Okay, so this is about MRI. So let's discuss few words about endoscopy. So endoscopy, who will speak out? Zishan?
Yes, sir.
Okay, so a few days ago we discussed about this upper GI bleed. Just general concerns, endoscopy, what things you need to take care in patients going for endoscopy, the limited access and this unfamiliar environment and limited manpower we have discussed. So go from there on. General concerns we have discussed. What will be the specific things with reference to endoscopy?
Sir, we should on the basis of thorough history, we should assess the severity of the patient and comorbids of the patient regarding the patient. Uh, Patient can undergo endoscopy or not. Is he fit to undergo endoscopy? We have to rule out. Uh,
Okay.
Other than that,
Can you delay the endoscopic procedures?
sir, we can discuss with the uh, with the treating physician, and if there is a delay, we can delay it, sir. But there are few conditions in which
Usually
delaying
you cannot delay. Actually, majority of conditions for which the endoscopy is being, you cannot delay the CBD stone. You cannot delay the upper GI bleed. Okay. So what procedure
yes,
they are coming for which you can delay? Only few procedures, because
sir,
in
diagnostic.
endoscopy, diagnostic procedures can be delayed if they are not cancer. If they are not suspecting
Yes, sir.
cancer, then maybe it can delay. Cancer, we cannot delay. Okay, because cancer patient, if you
Okay,
delay, there will be chances of spread. So even in that patient, you cannot delay. What else?
sir. Then the specific use of opioids sometimes can cause sphincteropodia contraction that can have difficulty in operating for operating physician
So
to.
how they deal with it?
So they can give antispasmodic drug for it, sir.
No
Uh,
spa or Buscopan. Okay. Uh,
yes, sir.
I have a question about it. Like practically, I don't know whether I'm correct or wrong. Can we use glycopyrrolate for that effect? Because it's also antispal. It's also sympatholytic, sorry, parasympatholytic. So
Yes.
No, sir,
why
it has
can't,
very little activity.
sorry?
No, sir, we can't use glycopyrrolate. It has very little effect on that system.
Okay. Are you sure? Because in my opinion, both are same. Hyoscine, what's difference between hyoscine and glycopyrrolate?
Sir, hyoscine is preferred in GI symptoms. Like it has
Okay.
only only greater antisiology effect than other both of atropine and the hyoscine.
Yeah.
Yes, Bilal, you want to say something?
No.
Okay. Okay. So, but anyways, because I couldn't check it out, so please, if you can check it out, what will be difference between hyoscine and glycopyrrolate with reference to decreasing the tone of sphincter foci. Forget about secretions. We are not giving for secretions. We are talking about the tone of sphincter foci. So maybe anyone can Google about it. I couldn't do it. It was a question which is in my mind. Unfortunately, I couldn't check it out. So you don't. I'm not saying you don't say it, because when you don't need to prove that you can give glycopyrrolate. This was just striking my mind. So okay, this is one thing. So bleeding patient, all the things we have discussed already with reference to upper GI bleed. Here, another thing which will be there, the high risk of vagal stimulation. Okay, especially if they are doing colonoscopy, because endoscopy procedures, some of them will be they are doing not only the upper GI endoscopy, they are doing the lower GI endoscopy as well. What conditions are suspected in which they are doing pan endoscopy?
Sir, when there is polyp, when there is some cancer suspicion, when there is stricture, some ulcer, some Crohn's or ulcerative colitis like diseases.
Crohn's disease, ulcerative colitis. Okay, so
Yes, sir.
this is, so here be ready for uh, this
Radical.
vagal response. Okay. Another thing, will there be any advantage of opioid-free anesthesia?
Yes, sir.
Will there be any advantage of TIVA, TCI?
Yes, sir. Yes,
Will
sir.
there will be okay, because some of people, they are doing it in uh,
If-
uh, 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 different mechanisms have different application. Have seen reduces the amplitude of sphincter, leading to, on the other hand, is muscarinic antagonist and primarily inhibits secretions, making use in perioperative care and other social secretions. Okay, so it does not have much effect on sphincter of oditone. Thank you very much, whosoever is put it here. Uh, so another thing, there are two different ways of performing the anesthesia. They are doing it in which position? What is the patient position
Uh,
for endoscopy?
Lateral recombinant.
left lateral position usually they use for.
Okay, lateral or semi-prone?
Sir, our gastroenterologist use left lateral position whether he do gastro endoscopy or he do
Actually, the
ERCP or
position
he
is not purely left lateral. Left lateral position is something else. Left lateral position is what we make in the thoracotomy, or so it's actually semi-prone. Lateral, yes, you are right, it's less lateral, but actually it is sort of semi-prone. Okay,
oh,
semi-prone position, lateral, and you can say lateral or semi-prone position. So, and then another thing they need to put, there be role of lidocaine spray or
yes, sir.
lidocaine
Yes, sir.
gargles, because a number of
Yes,
time when they are doing it under monitored anesthesia care with conscious sedation or moderate sedation, they can do without intubation. Okay. Yes, there is risk of
yes,
aspiration, but because a number of time they are doing it, so they can aspirate. They can aspirate a lot of material through the this through the endoscope. Okay, and if they are doing a quick, a number of time they are doing it as without intubation. They are doing it with the moderate sedation with the like dexmedetomidine or propofol infusion, okay, ketofol. So there are so many ways. So, but in exam, if they are asking you, you say that if you have any doubt, you will secure the airway. Okay.
wait, yes, sir.
Yes. So you like you don't need to fight with the examiner that you have to do it without intubation. There is no fixed rule about it. You can say it can be done without intubation, but if you have any doubt, I will not take a chance. I will secure the airway, because securing the airway is the most important thing, and the position is not very good, so it's sometimes it's difficult to maintain the airway, and if you have to maintain a good depth of anesthesia. That's why the role of gargles will be vital, that if you have topicalized the airway, or topicalized even if you have put without before they put the colonoscope with endoscope through the rectum, if they have put a good amount of this this one lidocaine jelly, okay, this will reduce the requirement of anesthesia. So this is the cause actually. If they are doing diagnostic, or even if they are doing ERCP, it's not a painful procedure, okay. So the most painful step is that one, they are passing the scope through the mouth. So as soon as it passes through and enters the esophagus and stomach, it becomes it's not a very painful procedure. So that is the rationale behind doing it without intubation. So because you can maintain it. So but it's a 50-50 chance, and if you have any doubt, you will maintain the airway. Okay. So in that way, you can answer this question in a better way. So as Zishan started answering, that the patient whosoever is coming, you have to make sure you optimize the things which you need to do. Like if a patient with liver failure can come for upper GI bleed, so you should know this is a patient with liver failure, and you have to think about the Child-Pugh score and all the complication of hepatorenal and hepatopulmonary, everything which you can face in a CLD patient. This is one block. And because in this scenario that you don't need to tell each and everything, so you can just say that I will make sure I know the risk involved in a patient, in such patient, and where the patient falls, which class of Child-Pugh patient is having, and if you want to, whatever corrections you can do before the start of the procedure and throughout the procedure. You can give albumin, you can give FFPs, you can if it can be removed, this ascites can be removed. So that will all help. So all the things which we'll discuss with reference to liver failure will be there. Then another category of patients will be coming, that is post liver transplant patient who have some strictures. So that will be another category of patient, and that category of patient will be taking immunosuppressants. So post liver transplant patient coming for endoscopy for strictures and things like that, you should be thinking about immunosuppression. Okay. And because of course the liver will be functioning, but if the liver is not functioning, still if there is any rejection or something like that, you have to make sure that you are not giving any medication which is damaging the liver. And because of immunosuppressants, multisystemic effects will be there, so you have to make sure you have look into consideration what are the side effects of immunosuppressant patient is taking. So this will be another category of patient you can have. Okay. So I think we have covered almost majority of things with reference to endoscopy. Any point which I have missed, please do mention.
Sir, they use radiation, so we have to take care of protective
Yes,
gear.
yes, protective. Actually, I think you have joined a little late. So in the common things for majority of the procedures, Nora, there is radiation safety. Okay.
Okay, okay.
So okay. So now,
Sir, can you
yes,
clearly differentiate between minimal sedation, moderate sedation? Because they can
yes,
ask, I think, about that
yes.
deep
Very good.
sedation.
Very good. What we say in our language, jeda bole, ohi bua khole. So you have asked the question, so answer please.
Sir, I think with minimal sedation, when we give verbal
What is minimum
response,
sedation? There is, minimum sedation is not a valid thing. Okay. This is
sir,
a funny word, conscious sedation. Conscious and sedation. What do you mean by conscious sedation?
sir, with conscious sedation, I think with some verbal or
Verbal
painful
communication.
stimuli, the
Verbal
communication, the
communication is
purpose
there.
is fine.
and patient respond either to verbal or minimum stimulus. Okay,
Yes.
so that is conscious sedation. And then comes the moderate sedation
Uh, Moderate sedation.
or deep sedation.
Yes, sir.
So, and deep sedation, and then the come GA. So what is difference between moderate sedation and GA? It's the
Sir,
airway.
here the patient is unarousable. Patient is
Unarousable,
not
but
aroused.
unarousable, but
Min-
not, sorry, maintaining the airway. So that is deep
yes,
sedation.
sir.
And if you are, the
Yes, sir.
patient is not able to maintain the airway, you have to maintain the airway with some airway device, that is G. Okay. And in moderate,
Yes.
patient is sleeping and patient has, you have to give, patient is responding on slightly bigger stimulus. So that is, and how you quantify them is through Ramsey scale.
Yes, sir.
Okay. So then
Yes,
another
sir.
concept, monitored anesthesia care will come here. Monitored anesthesia care with here in any procedure done under local anesthesia by the surgeon or without local anesthesia even, in which the patient is monitored by the anesthetist. It is the presence of trained anesthesia personnel with a standard monitoring. Okay. And with or without giving anesthesia. Okay, so it is monitored anesthesia care. So monitored anesthesia care, when we encounter for these cystoscopies, it's monitored anesthesia care. In the cath lab is monitored anesthesia care. Anywhere where you are providing MAC is the basic thing. And then MAC maybe with conscious sedation, or MAC with the moderate sedation or deep sedation, everything is MAC. Okay, so it is monitored anesthesia care provided by you. If it is now, like this is the concept of monitored anesthesia care. So ERCP, endoscopy, GI bleed, strictures, colonoscopy, diagnostic procedures, these are all the horizon of the thing which are there in endoscopy. MRI we have discussed, MRI, all the concerns we have discussed. Radiation oncology or radiations, they give even the this one, Arjun, they give this dyes, and you have to be, they are giving this chemotherapy or radiation. So there is a terminology which I don't remember exactly. Brachytherapy. I will show you because I don't remember exactly. So it's better to. What is brachytherapy? So brachytherapy involves placing sealed radiation source inside or near the tumor site, reducing the exposure to healthy tissues. So this is what is called as brachytherapy. Because Bilal has worked in Shaukat Khanam, so I thought that
Hmm.
Bilal, sorry. Okay. So has any one of you done this brachytherapy? I have not done it. So I'm sorry, I have no experience about it. So, but this is what is radiotherapy with the specific area. They can ask about this. They can ask you about this procedure, brachytherapy. I think once upon a time they had asked this in the exam. Okay. So you can have a look at it. Okay, so if they ask you about anesthesia care in a patient for acute MI, okay, so all the concerns of airway, breathing, circulation will be there. They are doing the angiography, but at the same time you have to make sure that you are ready for all the catastrophic problems. The perfusionist should be on board. The cardiac surgeon should be on board, because anytime they can rupture the vessel, the patient can have severe arrhythmia, even ventricular fibrillation, cardiac arrest. Usually they defibrillate from their side, usually by themselves, but you have to be ready. And at any point of time, if the patient lose the airway or hemodynamic instability occur, you have to treat accordingly. You have to give vasopressor or inotrope or antiarrhythmics or so. Answer is very simple. So you will be providing monitored anesthesia care. You have to be ready for all the complications, all, so they can ask you anything about it. Okay. So they are also giving the anticoagulants, sorry, antiplatelets or thrombolytics. Okay, and that's it. So interventional, sorry, this cardiac cath, they can ask you this question for cardiac cath. And then what else is left? ECT. What is ECT?
Electroconvulsive therapy, sir, it's
Okay.
a process of uh, conducting electricity by placing electrodes around the skull
Okay.
to treat refractory depression or uh, some other psychological illnesses.
Okay. So for anesthesia, what happens?
सर फर्स्ट इसमें पैरासिम्पथेटिक आता है और फिर सिम्पथेटिक रिस्पॉन्स आएगा.
So both
First there will be a parasympathetic response for
parasympathetic response leading to bradycardia. Okay.
yes.
And then
Then there will be sympathetic surge for 5 minutes, and in which there will be tachycardia and hypertension.
it can. Okay. So how to give anesthesia? Would you like to intubate the patient? Would you like which anesthetic agent will be better?
Sir, low dose propofol and low dose sux are used ideally
Why
because
to give suxamethonium?
patient may have rigorous movements and may cause damage to themselves and healthcare providers.
You are not telling the correct word. You are right. But here the when
Because
To prevent the bone and muscle injuries.
yes, to prevent bone and muscle injury. Okay, it can cause fractures. So that is the reason, because it's you are creating fits. Okay, and like there was a medication which was given. Not a, I don't think so. It's used now. Methohexitol. If I'm not wrong, this is just in my mind. Maybe correct me if I'm wrong. So because
Yes, sir.
it's not uh, causing anti-epileptic effect, because all these medications what you are using are what about Omidate? We see that it produces seizure. So why shouldn't we use Atomidate?
Sir, if we are doing a repeated sessions, then to maintain the adequate depth and duration of seizures, we usually use the same drug throughout every session.
So
So
that
if we
it
can
is
use
marked.
yes, sir. So
Yes,
we can use Accommodate to increase the duration of seizures.
yes. So because in this procedure they will ask you how to conduct, what are the complications, and then
How to conduct it?
how will you prevent the surge of parasympathetic or sympathetic. So for a parasympathetic, you can give
So
glycopyrrolate to
how to
maintain.
conduct it?
Yes, how to conduct it.
So how to conduct it?
Yeah, yes, Bilal.
How many of you have done this ECT?
So I think most of us have done it.
How you
Sir,
do it?
How you
for
do? How you
uh,
do it?
yes, sir. First, we have to take the brief history and
That's
check
it.
the
Pre-op is
documents.
done. Pre-op is done. Okay, we agree that we're gonna anesthetize this patient. Okay. How you conduct
Medical.
it?
Sir, for conduction of anesthesia, we would pre-oxygenate, we would do induction, like the drug has been discussed. Propofol is most of the time used. I would use propofol
Okay.
for induction, and then I would give muscle relaxant, and after that, I would ask the psychiatry team to apply the mouth gag and of course the electrodes on the skull area where they use. And when the patient is relaxed, with bite block, and there is no risk for some tongue and other muscle or bone injuries, then they would apply their electrical stimulus, and on the staff would hold the joint areas like knee, ankles, and things, so that there is no joint dislocation or thing. The seizures would actually be induced, and the EAG monitoring would be done
And
after
how
brief.
you okay? Mhm. Keep
Yes,
going.
after
Sorry, I interrupted you. Keep going.
After brief seizures,
Mhm.
I would check an eye on the monitors for his or her hemodynamic monitoring for the parasympathetic response and followed by sympathetic response. Meanwhile, I would again, when they remove they end up with their seizures, induced seizures. I would again check for the airway. And I would ventilate the patient and would do
So
suction
which
so that no
medication you
stimulus.
use for your induction?
Sir, propofol,
Propofol. Okay. Any relaxant you use that?
sir, succinylcholine we use.
Okay. So
I
if you
use.
give somebody sucks, you gonna move it or no? Patient will move or no?
A patient would not be moved. Sir.
Okay.
Would not
So
move.
you paralyze the patient, right?
Yes, sir.
So how will you demonstrate the seizures to the team? How they will know that they have given appropriate grunt and they achieve their goal? Because
Sir,
they
the
wanna see
seizures.
seizure, right?
Yes, sir.
They wanna see it or no?
Sir, they would see it on the EEG monitoring on the monitor they have, because there would be changes in the EEG.
Okay.
Yes,
Okay,
sir.
that's how you do over there. Okay, but there is a little bit difference that here we do ECT. We put a blood pressure cuff on the ankle. Okay, and we inflate the cuff to a pressure above, few millimeter above the systolic level, which we see on the cardiac monitor as a baseline, and we inflate it before giving sucks. So the reason is why to inflate it, because when we give sucks and they shock the patient, still you can see some jerks on that ankle to make sure that they achieve their target. So that's a different practice here in US. So that's why I was asking this question. So you know what I mean? When you paralyze someone, right? So all muscle gonna be paralyzed, but we inflate a blood pressure cuff on one of the ankles so that sucks cannot reach beyond that level, and still those muscles are spared, and we see the jerky movements there.
Yes, perfect. Bilal, thanks a lot for your this point. And actually, the same technique is being used in isolated forearm technique for the monitoring of awareness. Same
Yeah,
technique
Sir,
is
I did
and
there.
not.
second, yeah,
Sir, Sir Zishan, can you explain? I did not get the Sir
No, no,
Bilal
no.
point.
Listen. I will explain. I will explain again. Bilal is saying that they will put a tourniquet or they will put a BP cuff you sustain so that the medication or any medication you are giving like muscle relaxant is not reaching the foot. Okay, you block it.
Okay.
So when it is not going there, when they demonstrate the fits,
Seizures.
it can be shown over there. Got it?
Yes, sir.
Okay.
The BP cuff acts as the tourniquet, or we say like in while
As a
block we.
tourniquet.
yeah,
Like not
yes, yeah,
necessarily BP cuff, like they can put a tourniquet like that. Okay.
yeah.
And actually, this is
Mhm.
the same theory is being used in this isolated forearm technique. You will see it in the topic of awareness. They used
Yeah.
to use it for some time. Very
Okay.
good point. Thank you, Bilal.
And
And
second thing is that let's make a little bit, problem-based learning that you are in a GI suite, because you guys are going for your oral board, so you know everything. So what Zishan is doing, he is trying to do very primitive teaching. Actually, what he talks throughout an hour, you guys should know it, and you should push him back on his toes that we know it. we need to learn something new. For example, a 7-year-old male comes for screening colonoscopy in GI suite, and he's a smoker, okay? EF is borderline, let's say 40%, smoker, diabetic, hypertensive. Heart failure is controlled, he's not decompensating. And the person who is doing procedure, he's keen to do that screening colonoscopy because he has a family history of CA colon and he comes in the GI suite every 6 months. And you see a CAT scan or CT scan and you find infrarenal AAA, which is 6.5 centimeter. And the last scan 6 months ago was saying 5.5 centimeter. So what is your rationale? Yeah, what is your decision that are you gonna do it? You explain everything to the patient that your aneurysm may rupture, and surgeon in front of you on the same bedside, he's saying that I am okay to do colonoscopy, but the anesthesiologist is denying because that's a common culture. It happens in US even. Okay, so how you gonna save yourself that you are in non-operating room settings and you got this scenario? Maybe this was a bad day for you. So what are the thoughts of the house about it?
Sir, is he optimized? Like if he is on some medications,
He's
antihypertensive?
optimized. He is optimized, but his AAA is 6.5 now. AAA means abdominal
Abdominal aortic
aortic
aneurysm.
aneurysm. Okay. It's a 6.5 centimeter. And on the last scan, 6 months ago, it was 5.5. And let's say it's infrarenal even. So how comfortable you are. The GI specialist saying you, I'm gonna put a scope from the bottom and I'm gonna look at it. But of course, the AAA is around there. So what are your thoughts? Any risk of rupture? Or are you comfortable to do it? And it's always almost the midday already, but he want to do it. And he's making an argument that this patient is a high risk to 12 CA colon because his father, his sister died of CA colon.
My argument would be that he is at higher risk of getting his aneurysm ruptured. So either he should
But
be
he's saying you colonoscopy is a low risk procedure.
sir, but there can be a sympathetic surge and increase shear wall forces and can cause a rupture or
Yeah,
aneurysm
they
to
can cause
increase.
rupture. That's fine. But how you gonna document or what is decision?
Sir, I have to ask whether it is emergency or it is urgency because of this his
He's saying
cancerous
urgency,
situation.
and he's saying that, and procedure is saying that this patient has been on clear fluid for 2 days and he's super hungry. For me, it's very hard to prepare his gut again.
Sir, but still, I think we should consult the vascular surgeon for it before doing that because it's
Vascular
urgent, not.
surgeon is doing another angioplasty in OR downstairs.
Okay, you mean he is not available on phone even? Can we
Yeah,
ask some
yeah. His
cardiologist?
resident is saying that we will get back to you. We are busy.
Just tell me,
They are,
Safiullah, just tell me one thing. What
uh,
vascular surgeon will do at this time? Because the answer is very simple. That this screening is with reference to CA. So there is a one thing which can put the patient with, if they don't do it and cancel it and reschedule it, maybe the cancer is there and cancer is spread. So this is one thing on one side, and the other sign is there is a atomic bomb inside, it can rupture. So you just have to do risk versus benefit. You will avoid all the
yeah,
risk factors and you will proceed with it. You have to do it. You cannot delay. Yes, you will do all the
Uh,
precautions.
you know,
You can
okay,
have.
that is another thought, but still, I'm not able to do it. I'm not comfortable. I'm saying I cannot do it. If I am
yes, sir.
anesthesiologist, I'm saying no. So what is the option? Can we
And
move the patient to some controlled area, like more help available, more, experts are around?
Yes,
sir, we
yes, sir.
can
I
perf-
opinion is
sir,
also yes. Continue, please.
sir, we can schedule patient for this procedure to be done in main OT, sir, so that in
Yeah,
a controlled
Manova,
environment,
yeah.
sir. Yeah.
And what else? Yes. So you can say him, okay, we are okay. We can talk downstairs to some floor manager or some booking to the nurse front station who is booking the patients, and you move the patient down and bring your tower down and keep, vascular surgeons on board once they are okay in their room. So we can do it downstairs, but otherwise it's not safe. So the whole learning is that anything which is happening in outside OR, they are low risk patient in terms of the procedures. But if you look at their clinical predictors, they are always high risk. And it is very hard to educate the non-anesthesia physician, like person who is working in MR or brachytherapy or radiation or endoscopist, because they their thought is only projected to find the holes of their interest, so they don't believe you, and sometimes even the patient is being wheeled by them and they see that patient very first time. So always careful about it, and whatever sedation you use, I know people use many drugs, but it is always safe to one drug at a time, and the best medication is propofol. I have seen now the people are switching their practice to the Presidex, but of course these are day cases, and Presidex is a good drug. The reason is that if you use Presidex, there is a less risk of airway obstruction, but it blocks the ganglia sometime, especially in GI suite for colonoscopy patient who are volume depleted already because they are on bowel prep for more than 48 hours. So sometimes Presidex causes hypotension, and it's very hard to pull their pressure up because your pressure, ephedrine, phenylephrine doesn't work, fluid doesn't work, head down position doesn't work. So though the propofol has chance that someone may obstruct the airway, but you can open the airway with nasal airway or oropharyngeal airway, or if it's, they are so deep or they are not being maintained, you can throw a LMA. But I feel that because in America, this is a business that every healthy patient starts getting colonoscopy or endoscopy. Even I am 41 now. So my GP is saying you are due for colonoscopy, but I'm saying that I'm not comfortable. I'm not gonna do it. I'm okay. So we do the regular list here on for these cases. So the take home is that use one drug at a time. Do not use too many drugs, and your workstation should be as equipped as a regular OR, and always keep an eye on everything. So probably I have seen people bleeding down outside OR. People are throwing a line on them, whiteboard cannulas on them. They are going back to ICU, and few sicker cases like they want to do PEG tubes on them, ICU patient, on GPNs. So you always get a very sicker population there. So, it's hard to deal with that. And here we say that less is always more, which means that always give little bit of medication, and because you have always room to give more. So, and second thing is that keep my sentence that we should train our trainees in non-operating setting, just train them how to give a medication slowly. I don't know, the anesthesiologist has some itching in their hand. They are very keen to push medications in a rapid way, which is wrong. So in neura settings, you need to train yourself, always maintain your practice on one medication and train yourself how to inject slowly. That's it.
Bilal, a few words about brachytherapy. Have you seen? You must have done it in Shaukat
Yeah, I
Khanam.
have done the
So,
brachytherapy.
few words
Brachytherapy
about it.
usually people, yeah, people come for some CA uterus or CA rectum, and they put a very sharp needle in perineum. So we used to do brachytherapy with combined spinal epidural. The reason is that sometimes they put needle and they do 2 sessions of brachytherapy. One session upfront in the same station, like in the morning we did CAC and they will do brachytherapy, and they say that we want to do another session after 8 hours. So in few centers, practice is to give GA, but we were not in the favor to anesthetize someone twice within 24-hour windows. So if we look at the patient, we speak to proceduralist, and if he or she say that it's going to be 2 sessions in a day, one in the morning and one in the afternoon, we used to do combined spinal epidural until unless there is no contraindication. But if it's one session, usually we used to do GA with LMA, a tube based on your expertise and based on your preference.
Thank
And
you.
it's a painful procedure. It's a painful procedure because those needles are really wide bow and long. They are deeply thrown in the body. So when patient wakes up, they are really in pain. So we used to be very comfortable if we do some regional like spinal or combined spinal epidural, because it helps them to tolerate those foreign bodies, those metals also, those big needles.
Thank you, Bilal. So, I hope we have tried to give an idea about this non-operating room anesthesia. Um, any questions or anything more? Basic anesthesia evaluation will be the same. Basic anesthesia safety should be the same. And because when they are asking this question, you don't need to say that I will take history, I will do. You can see I will do the risk stratification according to the history examination and investigation to see how is the
And one question is
yes.
very interesting. They ask about quench phenomena in MR. Anyone has an idea about it?
Sir, do you
Quenching.
mean how it happened or when it should be done or
Yeah,
things like that?
yeah. What is quench phenomena? Can we stop the MRI machine?
Sir, it is done only in emergency when emergency occur. Then I think
Which
it has to be
emergency?
like if some life-threatening situation, if some ferromagnetic material stuck or a person's life threatened because of the unavoidable hazards which was not avoided. So then they stop it, and then the stop
No,
it
let's say
suddenly.
if a metallic cylinder went as a projectile, right? It was pulled by a magnet and it breaks the machine. Which fluid gonna drain out? Which liquid they are using to keep the magnet cool? Because
Sir,
MRI
helium.
machine never stops. Yeah. So what helium does?
Sir,
If
helium
helium
is
starts
in the
leaking,
point.
what it does?
So it
Sir,
will
helium
create
is
a
in the
hypoxic environment nearby, sir. It will move out oxygen and hypoxic environment
Yeah.
will be created,
So
sir.
helium sir, converts liquid into gaseous form.
Okay. Then what happens? It causes hypoxia, right? It absorbs all the oxygen in that room, right? So what
Yes,
is
so
quench phenomena? You can Google also. You can Google.
yes, so this is what is Google is saying. Quenching is the
Hmm.
process whereby there is rise in temperature in the magnetic coil windings. This introduces resistivity in the coil winding, which reduces the magnetic field and produces heat that rapidly converts liquid helium into its gaseous form, and it will cause hypoxia.
Yes.
Yeah.
It
So they
actually
ask it
displaces
there.
the oxygen.
Yeah.
So you have to remove the patient out of the suit immediately, and
Yes.
so that you and even you can become hypoxic as well.
Yes.
Yes.
Okay, so thank you very much, all of you. Bilal, tomorrow are you free? You were talking about a session with reference to the long case. So if you are free tomorrow, we can have that session.
I don't know. It depends on schedule tomorrow. At work now. I'm just going out to pick my son. So
Thank
I
you.
got relieved earlier today, but I don't know. Tomorrow I will try.
Anyways, so let's
Yeah,
hope
yeah,
for
I'll
the
try.
best. So
Mhm.
same because tomorrow I will take another session slightly early. So if you are free at this time, Bilal, I will coordinate with you and we will have another session. So tomorrow I will try
Okay.
to discuss some of another topic, maybe
Mhm.
ICU, because tomorrow is like my weekend, so I can have early another session. We have discussed a number of things. Maybe I will try to have ICU. Okay, and
Mm.
one topic which I'm running, but I will try to do it as much as possible. This physics. Bilal, we are not able to catch Salman. Do you know, just because we are very close friends, and I just told about Bilal recently had a the tutorial anesthesia tutorial of the week, mashallah. So it's a great honor, at least for me as a Pakistani FCPS fellow, that mashallah Bilal has written a anesthesia tutorial. So it's a big moment of pride for all of us. And one of my friend, he's in Medina. Unfortunately, they are not interested in teaching, but actually they are my teachers. One of them, Awais, his name is Awais Tahir, and one of them, our common teacher, Bilal, is also his what you say, murid, and we are all like I owe a lot to Salman, but unfortunately we are not able to catch him for teaching, especially the basic sciences. He's very good
Yes.
at it. So,
Yeah.
inshallah, I will try to have one session on this. This is another thing which physics equipment monitoring. Okay, this is one is left, and at the end, because Dr. Fazal has told in detail, they have discussed all the topics related to cardiovascular system and respiratory, but still we will just try to at the end. But we are not sure what will be the situation in our country now, that we will the exam will be there or not. But anyways, thanks a lot, all of you. And inshallah, tomorrow, most probably, I will take a session around 6 p.m. Pakistan time. Okay. I will send the link.
Okay.
Okay, everybody,
Thank you,
thank
sir.
you. And a special thanks to Bilal for pulling out his,
No
his
problem. No problem. Thank you.
okay, bye bye.